Tonight's lecture is about sleep and rest. That's chapter 19 of your textbook. The lecture about sleep and rest is a topic nursing students know very little about because, as you all know, nursing students get no rest and no sleep. There is a difference between light sleep or napping and what we refer to as restorative sleep. Restorative sleep is accomplished when the person wakes up feeling rested, refreshed, rejuvenated, and energized. After restorative sleep, the person awakens feeling ready to meet the day's challenges. When a person is sleeping restoratively, the muscles are totally relaxed, vital signs are slowed, and the body becomes immobile. External noises are filtered out and do not cause the person to wake up. During light sleep or napping, the person is easily aroused by external noises. Resting does not necessarily mean sleeping, although you have to say that you do feel rested when you wake up from restorative sleep. However, you are resting anytime you feel relaxed and anxiety-free. For example, you may be resting when you sit by a pool reading a book or when you're invited to have lunch with friends. I probably should have put there when you're invited to have a virtual lunch with friends, at least until later in the summer. It will probably be like that. What are the benefits of restorative sleep? In order to maintain optimal mental and physical health, the body must have adequate restorative sleep. When a person is sleeping, the brain is able to process and sort out the stressors of the day. These would be stressors to the body, mind, and emotions. During times of trauma or illness, the body needs even more rest and restorative sleep than it does normally. The benefits of restorative sleep are, number one, healing and tissue repair. Without restorative sleep, healing time is slowed and incomplete. Proper functioning immunity. Without restorative sleep, your immunity will decrease. Pain tolerance ability. When you don't have enough restorative sleep, pain tolerance is lessened. Emotional stability. Without restorative sleep, emotions are more fragile and a person becomes irritable and impatient. The fifth benefit is that you have maximum cognitive functioning when you've had a restorative sleep. Without it, the person has difficulty focusing and concentrating and has an impaired decision-making process. This is why you need a good night's sleep before a test. You have a better work performance and work at your optimum ability if you've had a good night's restorative sleep. There's less accidents when you've slept restoratively the night before. Without restorative sleep, accidents increase dramatically. I'm talking about things like falling asleep, like when driving, forgetting to turn off the stove, and you can probably think of a million other things. A good night's sleep allows the brain to rejuvenate. A good night's sleep allows the brain to rejuvenate. The central nervous system is able to sort out and process the stressors and problems of the day. When you wake up in the morning, you're better able to solve the important problems of the day before and filter out what isn't relevant. How much sleep do we need? Well, to tell you the truth, the amount of sleep an adult needs varies from person to person. Only you will know if you got enough sleep the night before. The average amount of sleep required by an adult is 7 to 8 hours, but some people function fine on a little less sleep, while other individuals need a little more than 8 hours of sleep to feel rested. It's also affected by where you are in your growth and development. A newborn may need up to 18 hours a day of sleep, while an older adult may only require 5.5 hours. If you look on page 586, you'll see a chart of the amount of sleep per average that each age group would probably need. Going back to what I said before about the average is 7 to 8, and some people function on a little less and some on a little more. By a little, I mean a little. That doesn't mean if you average 7 to 8 hours of sleep, another person can sleep 2 or 3 hours and feel fine. I mean by a little less, maybe 6 hours, and a little more, maybe 9 hours. Next, let's talk about the sleep cycle. And if you will look at the outline, there is a picture of the sleep cycle at the head of this topic. Sleep is thought to be something that happens once every 24 hours. But the little snag in this is that probably 1/2 of the world population has an afternoon nap or siesta as part of their lifelong sleep-wake pattern. Remember, restorative sleep is accomplished by varying degrees of unconsciousness and inactivity. So therefore, if a person is actually achieving restorative sleep during the siesta, it would create a variable in the 24-hour cycle. But that's a variable and something that I don't have any facts on, so let's put the siesta aside and base this lecture on the fact that the body has a 24-hour cyclic pattern known as the circadian rhythm. The circadian rhythm is the internal system we have that influences our levels of ability. The metabolisms and functions of the body increase and decrease in rhythmic patterns. For example, body temperature is lowest in the pre-dawn hours, and body temperature is at its highest in the late evening hours. This is if you sleep during the night and are awake during the day. This whole circadian rhythm would be reversed if you worked the 11 to 7 shift. So therefore, sleep and wakefulness are cyclic. During a 24-hour time span, a person has a period of sleep, 7 to 8 hours, followed by a longer period of wakefulness. There are 2 sleep cycles that we know of. The first cycle is the non-rapid eye movement cycle, or NREM. And there's a rapid movement cycle, which is REM sleep, REM. Non-REM sleep is considered the deepest and most restful of the 2 cycles. Non-REM sleep is made up of 4 stages. REM sleep is made up of just 1 stage. Non-REM and REM sleep alternate cyclically throughout the night. Non-REM sleep, stage 1. This is when the individual starts to transition from wakefulness to sleep. They begin to relax. The metabolisms and the vital signs start to slow down. The person will fall into a light sleep. However, they're very easily awakened. And when they're aroused, the person often feels like they've been daydreaming. Stage 1 lasts only for minutes, sometimes seconds. Next, the person moves into stage 2 non-REM sleep. the body becomes even more relaxed. Metabolisms and vital signs slow down even more. The person starts to experience sounder sleep. However, they're still relatively easy to arouse. Stage 2 is going to last from 10 to 20 minutes. Stage 3 non-REM sleep, the muscles of the body become totally relaxed in deep sleep. What we are talking about, restorative sleep, begins. Your metabolism and vital signs slow down significantly, and the body becomes immobile. At this point, it is difficult to waken the person. This stage lasts from 15 to 30 minutes. Stage 4 non-REM sleep is another stage of restorative speech. So stage 3 and stage 4 are restorative speech. In stage 4, the body is in its deepest sleep state. This is the place where the body totally rests and restores itself. During stage 4, muscle and tissue repair take place, the immune system is boosted, and the body builds up energy for the next day. It's extremely difficult to waken the person. Although there is no eye movement, your book says that dreaming may occur during stage 4. But that's debatable. Usually it's said that it's in the REM sleep, but I thought I'd put that in there because it is in your book. Stage 4 lasts 15 to 30 minutes. If a person has been deprived of sleep, this stage will last longer. Remember, stage 3 and stage 4 are your restorative sleep cycles. During stage 3 and stage 4, the brain produces delta waves. Delta waves are the deepest and slowest of the 5 types of brain waves a person experiences during a 24-hour period. When delta waves are visible on an electroencephalogram during a sleep study, the technician knows the person is in a completely unconscious sleep state. Immunity, growth, tissue repair, and muscle repair are enhanced. After stage 4 of non-REM sleep, the person moves into REM sleep. REM sleep is rapid eye movement. So non-REM sleep is no rapid eye movement. REM sleep happens at the end of every non-REM sleep cycle. Rapid eye movements begin, vital signs fluctuate, blood flow to the brain increases, and your metabolic rate increases. The brain is very, very active during REM sleep, and vivid dreaming occurs. Dreams may or not be remembered after the person wakes up. The length of time REM sleep lasts becomes longer with each sleep cycle, and the non-REM stages get shorter. REM sleep is much less restful than non-REM sleep, but it's very important to learning and memory. This is the time when your brain processes and consolidates the information from the day before. It's that at this point that the brain decides what to commit to memory and what probably wasn't that important and to file away and not think about again. After REM sleep, the cycle starts over again and you go back to stage 1 non-REM sleep. Late into the night, one REM cycle may last up to 90 minutes. However, on an average, a REM cycle lasts 20 minutes. A person experiences 4 to 5 complete sleep cycles every night. There are many things that affect your sleep and rest. Ideally, we are all getting our 7 to 8 hours of sleep, and going through the sleep cycle in a fashion that finds us relaxed and restored the next morning. Unfortunately, this is not always the case. There's many things that can affect a person's quality of sleep. These factors may be physiological, psychological, or environmental. Sleep deprivation, or prolonged periods of time without sleep, are going to lead to a host of issues. Fatigue, irritability, slow response time, blurred vision, headaches, forgetfulness, inability to concentrate, and confusion. Severe sleep deprivation can lead to paranoia and hallucination. And remember, the effects of sleep deprivation are reversed when the normal sleep cycle returns. So as soon as you start sleeping normally again, sleep deprivation will be taken care of and cleared up. Your lifestyle affects your sleep. Everyday choices and preferences may affect how you sleep and the quality of sleep. For example, caffeine. Caffeine's a stimulant, and that interferes with your ability to fall asleep. Nicotine is a stimulant, and that's also going to interfere with your ability to fall asleep. Alcohol, which is a depressant, may help the person fall asleep initially, but it leads to interruptions in your sleep, and the person finds themselves waking up several times during the night. Work. If you work 11 to 7, you often have trouble getting enough sleep during the day. Your circadian rhythm needs to adjust to this new time change because it's totally backwards from the norm. Some people never can adjust to working this shift and have to go back to working days. Exercise. Exercise is conducive to sleep if it's done early in the day on a regular basis, but exercise is going to inhibit sleep if it's done 1 or 2 hours right before going to bed. Stress affects your ability to sleep. Stress and anxiety can interfere with falling asleep and can cause a person to wake up early. It's hard to fall asleep and stay asleep can be an environmental problem. The temperature of the room where you're sleeping. If it's too hot or too cold, you're going to have a hard time falling asleep, and you'll probably wake up hot or cold in the middle of the night. Noises, alarms, beeping, staff talking. If you're home, your neighbor's having a party, street noises. All those things affect your ability to sleep. Bright lights. When we go into the room and wake people up for nursing care, that affects their ability to sleep environmentally. And again, working 11 to 7. The person is subject to more outside noise, traffic, horns. I have to say, because I experienced it, the guy next door practicing his trumpet. I worked 11 to 7 when I lived in Boston when I was going to school. I'd come home. I lived in an apartment building. You know how the apartments are all so close in Boston. So I'd go home. First, I wouldn't know whether I should eat breakfast or supper, so I'd have to make that decision. After I did that, I'd go through my little routine and try to go to bed. Well, the guy that lived in the next apartment building was apparently an enthusiastic trumpet player. So about 10 o'clock in the morning, when I was just drifting off, he would start to practice, and he was horrible. He couldn't play the trumpet, poor thing, but he kept trying all day long. So I got some sleep, but I woke up often to the sound of taps. So outside noises when you work 11 to 7, and what are you going to say? He's not disturbing anybody's peace but my peace, because it's perfectly fine to practice your trumpet at 10 o'clock in the morning. Exercise, let's see, where did I leave off? Working, okay. Noises in the house also can affect your sleep. If there's other people in the house, they may be listening to the TV, radios, moving around, dropping things, clomping up and down the stairs. All those things affect your ability to sleep. Health problems can affect your ability to sleep. If you're in pain, it's very hard to sleep if you're in pain, if you can sleep at all. Shortness of breath or dyspnea, difficulty breathing. You can't get comfortable and fall asleep when you're not breathing right. Pruritus or itching. If you're constantly itching and it won't stop, you can't get comfortable and you don't sleep. Gerd, gastroesophageal reflux disorder, can affect your ability to sleep because the acid reflux is so uncomfortable and painful. Nasal congestion and coughing. You may go to sleep, but you wake up often coughing and blowing your nose. A fever, diaphoresis or excessive sweating, diarrhea and nocturia. If you have to get up either time to go to the bathroom often, it's going to interrupt your good night's sleep and your sleep cycle. So you may not be getting the restorative sleep you need if you've got health problems. There are some specific sleep disorders that affect a person's ability to sleep. The first one is bruxism. That's our fancy word for grinding the teeth while you sleep. It's caused by a dental problem or stress. To get rid of it, the best thing or the most hopeful thing is to eliminate the cause. Use good dental hygiene and go to the dentist to correct any problems. Learn relaxation techniques like yoga, listening to music, deep breathing. And then dental appliances can be fit to help a person stop grinding their teeth. You wake up in the morning if you're a tooth grinder with stiffness in your jaw. It's very uncomfortable. The next thing is insomnia. Insomnia is an impairment in the amount and quality of sleep a person gets every day that impairs functioning. Chronic insomnia is the chronic inability to go to sleep or stay asleep. People that have insomnia, you can teach them to not to go to bed until they're sleepy. I mean, myself, if I've got a lot of worries on my mind and I go to bed right after I've been active and I've got worries and I lay down, I just lay there and worry. That's not going to help. If you're not sleepy, stay up and do something pleasurable or relaxing to calm your thoughts. Read a book or watch TV. Try to zone out in what you're reading or what you're writing instead of the racing thoughts of the problems you face during the day. Avoid caffeine, alcohol, and strenuous exercise before going to bed. Avoid napping during the day. Sedatives are used only as a last resort. I'll talk about those a little later. They actually can cause more harm than good, and therapy may be needed for the person that is having insomnia. Third thing I want to talk about in the sleep disorders is narcolepsy. Narcolepsy is the uncontrollable recurrent episodes of falling asleep during daytime hours with very little warning. This can make operating cars and heavy equipment dangerous. Typically, the narcoleptic patient will have several episodes. These episodes are called sleep attacks every day. Scheduled naps during the day may help prevent daytime sleep attacks, especially if they can be timed to occur at times the patient usually experiences a sleep attack. The patient may be treated with stimulants like Adderall and Ritalin. But remember, the most serious problem with narcolepsy is the person might engage in activities that require constant alertness, such as driving or piloting an airplane. They may suddenly have a sleep attack when they're up in the sky, flying that plane, and have the irresistible urge and not be able to stop from falling asleep. In many states, people afflicted with this disorder need a healthcare professional's letter stating that it is safe to drive, fly, operate heavy equipment, etc. At the first sign of drowsiness, if the person is driving and they have a little aura that they're getting narcolepsy, they should drive to a safe place. Even if they're not driving, they should sit down so that they'll be safe, and seek a place where it will be safe for them to sleep until the attack passes. The next type of sleep disorder is somnambulism. Simply means sleepwalking. There is no specific treatment or cure for sleepwalking. If the somnambulist engages in risky behavior like while sleepwalking, safety measures can be instituted to avoid injury. For example, you can hide their car keys. I have an alarm on the door to alert the family, put them in a first floor bedroom, lock up fire alarms, lock windows, things like that. If the person is a sleepwalker, they often outgrow it. Interesting, and there's a lot of cases on it if you look it up on the internet, but interesting, sleepwalking has been used as a legal defense. Although rarely have people been acquitted of murder, they have been acquitted of murder because they're sleepwalking and they don't know what they're doing. Medications. Medications can be known to cause sleepwalking, notably Ambien. Two cases I can think of that were in the news not too long ago. This Tiger Woods was out driving. It seemed at first that he was probably driving under the influence, but he had not had any alcohol. What it turned out to be was Ambien, which is a sleeping pill, and he had no recollection of going out and driving the car. So it was the effect of the Ambien. And that also happened to Patrick Kennedy, a politician from Rhode Island, where he was having insomnia, he was on Ambien, and he went out and was driving under the influence of Ambien, not the influence of alcohol, which caused him some problems as he wasn't driving safely. So the next one is something you've probably heard more people complain of. It's restless leg syndrome. That's a condition where the person experiences an intolerable creeping sensation or itching in their lower extremities, and it causes them to have an irresistible urge to move the legs. The symptom is worse when the person is trying to fall asleep, and there are medications that help with this problem. The next problem is night terrors. Night terrors typically are seen in children. Night terrors are a form of nightmares where the child experiences hallucinations. When they wake up, they're terrified and very afraid and fearful of going back to sleep, lest this horrible night terror return. Night terrors, unlike dreams, remember your dreams occur during REM sleep, night terrors occur during the non-REM phase. A person having a nightmare is going to wake up. A person in the midst of a night terror continues sleeping. There's no known treatment. Children almost always outgrow the night terrors by their early teens. If this is a safety issue, institute the same safety measures we talked about with sleepwalking. Taking away the car keys should the person be an adult, locking up firearms, first floor bedrooms, having a door alarm, and things like that. Sundowning is also a sleep disorder in the elderly dementia patient. They become confused, disoriented, and agitated in the evening hours and become a high risk for injury. The last one I'm going to mention and then go into more detail as we go along is sleep apnea. Sleep apnea means that you have the inability to maintain your breathing while you're asleep. Typically, the patient will be snoring. The snoring stops and abruptly is followed by periods of apnea, where apnea meaning they're not breathing. The period of apnea lasts from 10 seconds to 2 minutes, and it could be life-threatening. CPAP and BiPAP machines are prescribed after a sleep study to help the person lessen these periods of apnea. Also, people with sleep apnea are often obese and overweight, so a weight loss program, if obesity is contributing to the problem, will help lessen the sleep apnea.
When you breathe, air travels down your throat, through your windpipe, and into your lungs. The narrowest part of that pathway is in the back of your throat. When you're awake, muscles keep that pathway relatively wide open. But when you sleep, those muscles relax, allowing the opening to narrow. The air passing through this narrowed opening may cause the throat to vibrate. That causes snoring, which many people experience. But in some people, the throat closes so much that enough air can't get through to the lungs. When this happens, the brain sends an alarm to open the airway. Most often, this is associated with a brief arousal from sleep. The brain quickly reactivates the muscles that hold the throat open. Air gets through again, and the brain goes back to sleep. This disorder is called obstructive sleep apnea.
So, with chronic sleep apnea, the airway is obstructed. The patient is temporarily going to stop breathing, which is apnea. And at this point, they're not breathing, so they're not receiving any oxygen from the air, and they can't expire carbon dioxide from their body. Again, the periods of apnea last 10 seconds to 2 minutes. The signs and symptoms are often first noticed by the patient's partner while the patient is sleeping. The signs and symptoms are loud snoring, periods of apnea, gasping and choking, and awakening multiple times during the night, gasping for breath. In the morning, the person wakes up feeling fatigued and drowsy and has a headache. They often complain that they just didn't have a good night's sleep. Hypersomnolence is seen often in these people. Hypersomnolence means falling asleep during the day in unusual circumstances. It's not a sleep attack like they have with narcolepsy. This person is falling asleep because they didn't sleep at night. So, for example, if I have sleep apnea and I'm sitting at a traffic light, I might just drift off to sleep. Maybe I'm sitting here at my desk, nobody's in my office, I'm reading my emails, I get drowsy and fall asleep because I didn't sleep the night before. Diagnosis, the signs and symptoms are pretty suggestive, but that's only a presumptive sign. A sleep study is needed to confirm the diagnosis. Sleep study is going to confirm the A sleep study is going to confirm the diagnosis and document the findings so that medical insurance will pay for the treatment, which is to get a CPAP or BiPAP machine. During a sleep study, by the way, the technical term for a sleep study is polysomnography. So during a polysomnography, there is a simultaneous monitoring of respirations, cardiac functions, your heart rate and blood pressure, and your O2 sats, your brain waves, and your muscle activities. So the person is pretty hooked up. They have leads on their heads, leads on their chests, leads in their muscles, a blood pressure cuff on, and an O2 sat thing. The test can be conducted in a sleep lab where the patient is monitored all night, or it can be conducted at home. Sometimes insurance won't pay for the sleep study in the lab until one is done in the home first. A sleep study may be useful in diagnosing narcolepsy, rapid leg movement, and chronic insomnia, but the main purpose of the sleep study is to diagnose sleep apnea. During a sleep study, the technician can evaluate the amount of pressure that is needed to keep the airway open so that the individual can achieve a restful sleep. This is going to help determine the correct setting for the BiPAP or CPAP machine in the future.
The sleep study, basically, depending on what we're looking for, the wires will be placed on the patient to monitor their brain waves, see when they're awake, when they're sleeping, eye movement, leg movements, want to see if their legs kick when they're sleeping. Some people have restless legs. It's not a matter of sleep apnea, but their legs keep kicking all the time. Anything that's going to interrupt the brain from resting is going to make the person tired. So what we do, we look at all the different aspects. You know, we want to see what your heart's doing, if you're snoring, if what your brain's doing. Do you get into a REM stage of REM sleep? You know, those kind of things. Are you talking during your sleep? Are your arms, you know, flaying? You having nightmares? Those kind of things. So once we can see what's going on with the different devices that we put on electrodes, then we can go forward and treat. You know, once we get that documentation. So they come in and we hook them up, and then we get them to bed to see. Some people don't sleep, and then there are others who sleep as soon as their head hits the pillow. It's quite interesting how that works, and no two people are the same.
They come in, and we go through and we do the registration with them on the tablet, and then we bring them back to the room. We show them all around the room, explain the controls, the TV control, the bed control, get them something to drink, make them comfortable, and then we come back and we explain the procedure. Then they'll be hooked up with all the electrodes. They can lay freely, turn however they want. They don't have to stay on their back. We want them to sleep how they normally sleep at home. Same as with any medications they take, we want it to be the normal. Then in the morning, we wake them up and offer them coffee, take all the electrodes off, and they're free to go.
Patients sleep better when they're comfortable. So when the patient comes in, they want to be able to lay down and know that this is a comfortable room, it's cool, it's nice to look at. I have a TV with Wi-Fi in the room, and you know, I can relax and go to sleep. You have great technicians who work with them, and they talk to them. By the time all of that hookup process is done and everything, it's time for bed, they go to sleep. But if they come in tensed up and nobody's comforting them in any way, they're not going to sleep good. So that's our goal. Get them to sleep well, get them a room that's comfortable, and there you go, we have a good study.
So to treat sleep apnea, we have the CPAP and we have the BiPAP. CPAP stands for continuous positive air pressure. BiPAP stands for bi-level positive air pressure. They're very similar in the way they look, as you can see by the picture.
Oh, hi there. I'm Alan Guinea. I'm a second-year resident in emergency medicine at NYU Bellevue. My cameraman today is Dr. Salil Bandari, one of our attendings. Say hi, Salil.
Hi, Salil.
Today, I'm going to teach you how to use a non-invasive ventilator, also known as a CPAP or a BiPAP. Before I start, let me say that whenever you use one of these machines, you should page your respiratory therapist first. They know how to use them the best and will do all the work for you. However, there could be a rare emergency where you need to know how to set it up yourself. Here at Bellevue, we have a Philips V60 non-invasive ventilator. The machine has its own internal battery and its own internal oxygen supply, so it doesn't actually have to be attached to the wall and can travel with the patient during transport. Right now we have it plugged in with a black power cord and this green oxygen delivery cord, which is attached to our wall oxygen. The machine comes stocked with tubing and masks. The tubing is actually two tubes attached together. You have a large tube for delivering air to your patient and a small one for measuring the pressure of that air. You can tell the two ends of the tubes apart because one of them has an air filter attached to it. This is the side of the tube you want to attach to the machine. Let's attach the tubing now to these ports to the right of the console. Big to big, small to small. The masks come in sizes from small to large, and the mask bags have helpful cutouts on them that allow you to size the mask to the face of your patient. I'm a medium. The mask is plastic and sits over the patient's face. The mask is attached with this webbing. You can adjust the size of the webbing with this Velcro, and you can attach the mask itself by using these snap closures. Let's attach the mask now to the other end of the tube. And then let's set it aside. This is the control panel of the V60. It may look intimidating, but it's touch activated, and really it's just a big iPad with tubes attached. Let's turn the machine on with a button to the bottom left. This machine has a number of settings and a number of modes. You can change the modes by using the Modes tab located right here. This machine has both CPAP and BiPAP modes, but you notice that there's no button that's actually labeled BiPAP. In the case of our machine, the BiPAP mode is actually labeled S/T. That stands for spontaneous timed. It's a type of BiPAP mode where the machine can actually deliver a breath even if the patient isn't triggering it. Let's select that mode now by pressing the ST button and then the Activate button. Here in the Settings tab, you can change any of the settings for the mode you've selected. For instance, let's change the IPAP to 6 and click Accept. Let's change the EPAP to 4 and click Accept again. Often, patients have a lot of trouble when you first hook them up to BiPAP because the mask itself is claustrophobic and it's going to be pushing air down into their lungs, which can be very uncomfortable. One way around this is to attach the mask loosely at first and leave it off the patient's face, like an open door. Then, as the patient becomes more comfortable, you can slowly close the door over their face. Finally, you can take the last snap and snap the mask closed. Congratulations! You just learned how to use a non-invasive ventilator.
Both devices use pressurized air to keep open and keep the airway open and keep the throat from closing during the night. The difference is that the CPAP is set for one continuous constant level of pressure. The BiPAP is set to go on only if the person's breathing falls below the set number. When the air pressure falls below the preset number, the BiPAP is triggered to force air into the lungs to open the airway. So, remember this, a CPAP is set for a single pressure. A BiPAP is set to the timing of how the patient breathes. So a CPAP is set for a single pressure, a BiPAP is set to the timing of how the patient breathes. The amount of pressure is preset by the company supplying the machine per MD orders. Usually the patient uses a face mask, but nasal cannulas are available. Just recently they became available. Teach patients the importance of cleaning the tubing daily to avoid infection. The tubing in the mask can harbor infection, and the person can wind up with a respiratory condition. So that isn't helpful when they're already having trouble breathing. So the CPAP and the BiPAP tubing should be cleaned in warm, soapy water, rinsed thoroughly, and then the tubing should be hung somewhere to dry. The same thing with the mask, warm, soapy water, and make sure that the equipment is dry before using it again. It is a pain for people to clean them out every day, and a lot of people just don't do it. So encourage your clients to clean their CPAP and BiPAP tubing regularly. Also teach the patient to follow manufacturer's directions when they apply their CPAP or BiPAP device. If sleep apnea is untreated, complications can occur, such as high blood pressure, arrhythmias or irregularities with your heart rate, type 2 diabetes, increased risk of MVA, that's motor vehicle accidents, increased risk of falls, signs and symptoms of right-sided heart failure. Prolonged apnea can lead to brain death and respiratory failure. So if your brain, say you have one of those sleep apnea attacks that lasts longer than 2 minutes, and 2 minutes is dangerous. If it lasts longer than 2 minutes, it can lead to brain death and a heart attack and respiratory failure. What are some things we can do to intervene to promote restorative sleep? Most of this I'm going to talk about is when you're caring for somebody in a facility, but this can also pretty much translate into the home as well. You want to adjust the room temperature so the patient is comfortable and at their preference. What I find comfortable may not be what 90-year-old Mrs. Jones finds comfortable. So adjust the thermostat to their liking. Unfortunately, if you have two roommates and one likes it cooler and one likes it hotter, you may have the battle of the thermostat. So try to place the patient that likes it cooler nearer to the air conditioning and so forth. Pillows and blankets, adjust them until the patient feels comfortable. Make sure the patient is in a comfortable position. They might want the head of their bed raised slightly. They may want to sleep flat on the bed, however they feel comfortable. Change the linens if you need. Damp, wrinkled, dirty linens are not going to be very conducive to sleep. Plus, a nice clean bed will make the atmosphere more pleasant. Keep the pathways clear so the patient has easy access to the bed and bathroom. Dim the lights. You may use a night light just to have enough light for safety. Reduce the noise. Close the door if you can. Refrain from talking in front of the patient's room. If you are, try to speak in a soft voice. Lower the volume on TVs and radios if another person in the room wants them on. The hospital is a very, very noisy place. We have bed alarms beeping, call lights going off, IV alarms, people running in the halls, announcements coming over the intercom about codes. So those things are very noisy. They cannot be silenced, though. You can't silence bed alarms, IV alarms, and code alerts. They're there for safety reasons. But what we can do is respond to these things so the alarms don't continue for a long period of time. So if I'm laying in my room and my IV goes off, starts beeping that something's wrong, and it's like a white noise. You work in the hospital, you get used to it, beep, 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 and you just don't pay attention. But that person in the bed or the bed next to that bed is very aware of it. So try to respond to those and fix them in a timely manner so people can get a better night's sleep. Can ask visitors to leave at a reasonable time, especially if there's another person in the room. And then assist the person with storing their glasses, their dentures, their hearing aids. Straighten out the bedside unit, make the environment as pleasant and restful as possible. Comfort, the comfort of the patient. Assist them with hygiene, depending on the level of assistance needed. Wash their face and hands, brush their hair, complete oral hygiene. Try to keep it as normalizing as possible, like the routine that they would perform at home. Assist the patient with toileting and emptying their bladder. That'll help them relax and help them from waking up in the night to have to use the bathroom. Offer a snack at bedtime. Provide fresh water. Assess their pain and medicate as necessary. If a person is in pain, it's very difficult to sleep. And again, although an uninterrupted night's sleep is best, unfortunately, you're going to have to wake patients up for scheduled care. Vital signs, medications have to be given according to doctor's order. But we can try to accomplish these tasks efficiently and in a timely manner. Help the person to relax. Offer a back massage. Gentle range of motion exercises help to stretch and relax the muscles. Listen to what the client is saying. Allow them to verbally summarize any questions or concerns, or just talk about their day. Allow them to vent their worries and frustrations. Ask them if they want to listen to soft music or read. And unless medically contradicted, allow the patient to follow his pre-bed at home routine. Let's talk a little bit about pain. A patient may request pain medication. By the time the nurse gets back to the room, he or she is sleeping. So what do? What you don't want to do is assume that the patient really isn't in that much pain, because otherwise they couldn't have fallen asleep. Sleep is just a natural body mechanism for healing and repairing. And so the body will try to go into a sleep state. The patient in pain will fall asleep, but they won't stay asleep. Therefore, restorative sleep is never achieved. They never get into that phase where they're repairing and healing. So the pain could be helped while they're in restorative sleep, but they never get there. So don't ignore the patient's request for pain medication. Although it seems weird sometimes, wake them up and treat the pain. That way, the quality of sleep will be more therapeutic. Sleep medication, I want to talk just a minute about that. Medications used for sleep, for example, Ambien, are ordered as needed on a very short-term basis. Most sedatives and hypnotics are controlled substances, and the patient can build up a tolerance. Sleeping pills will interfere with sleep if they're used chronically, and they interfere with restorative sleep, and they also interfere with REM sleep. They should only be used short-term as a last resort when all other measures to promote sleep have been unsatisfactory. General measures that we can do at home to promote sleep. 1, go to bed around the same time every night. Take a warm bath. I was on call a couple of weeks ago. There's this patient I see for diabetic care and injections that has insomnia, so he called me up about 11 o'clock, and I'm trying to give him some ideas about how to go to sleep, and I suggested, why don't you take a warm bath? He said, a warm bath? I can't take a warm bath. That gets me more anxious than anything. I'm so afraid I'm going to slip and fall and not be able to get out of the tub. Why would you suggest I take a warm bath? So that being said, I guess taking a warm bath doesn't work for everybody. Try to relax and don't be involved in tasks. Don't decide you have to do your laundry and clean your kitchen floor right before you're going to go to bed. Sit down, watch a TV show, read a book, listen to music. When I say read a book, I don't mean to read a nursing textbook. LOL, I don't think you would. Avoid caffeine, cola, coffee. Avoid alcohol. Avoid exercising 1 to 2 hours before going to bed. Follow your normal routine. You know, whatever it is. Go in the bathroom, wash your face, brush your teeth, put your pajamas on, get your teddy bear and your favorite blanket, say your prayers, turn on the music, dim the lights. Avoid liquids in the evening so that you're not awakened to use the bathroom. Some people have nocturia. Remember, that means voiding during the sleeping hours. You want to try to help a person establish a routine so they can decrease the times they wake up to void. Number 1, teach the patient to avoid liquids in the evening. For example, maybe don't have anything liquid after 5 or 6 o'clock. Maybe don't have anything liquid after dinner. Cut back on caffeinated beverages, which have a diuretic effect and cause bladder spasms. Empty the bladder right before going to bed. Because if the person is getting up several times to go to the bathroom, they may be missing out on some of the restorative sleep that they need. If all these measures fail, and nothing has been helpful, encourage the patient to call his PCP for further evaluation to see if there's anything medically wrong. Now that is the end pretty much of the lecture, but take a little break because I need you to come back. I have an assignment to go along with tonight's lecture. Your assignment to go along with this lecture is to get plenty of rest and sleep tonight. Good night.